I have no financial interests regarding this video. Why do refractive surgeons avoid photorefractive keratectomy? Owing to the postoperative epithelial defect, almost all patients report significant pain, and an unhappy patient is never a good sight for any doctor. Extensive research into modes of analgesia after PRK has not yielded great outcomes. Our previous study, which involved the use of KETOROLAC soaked bandage contact lenses, showed some promising results, and the postoperative pain scores dropped significantly. We wondered if we could bring the pain down even further. History is inundated with instances of cold being used as a therapeutic agent, right from Napoleon's army to William Osler's body cooling regimen, and even the modern era of cryogenic surgery. David Julius and Adam Paraputian's research on ion channels perceiving heat and cold recently garnered the Nobel Prize. This made us wonder if we could introduce this concept in ophthalmology. We recruited 203 normal eyes undergoing PRK for the correction of their refractive errors and 249 keratoconus eyes undergoing cross-linking. These were further divided into 4 groups based on the bandage contact lens used. BCLs were prepared with thorough aseptic precautions. The conventional with ketorolac and cold with ketorolac groups were prepared by injecting 0.2 ml of ketorolac tromethamine 0.4% and allowed to soak for 20 minutes, whereas the cold temperature was maintained by overnight storage at 4 degrees Celsius. Our hypothesis was correct. The Wong-Baker scores on the first postoperative day showed significantly low scores in the cold and cold plus ketorolac groups as compared to the room temperature groups. We wanted to assess the period of time for which the contact lens would continue to release the drug in therapeutic concentrations. We performed high-performance liquid chromatography on the bandage contact lenses. Ketorolac concentration was analyzed at various time points and depicted in a chromatogram. It was found to reach its peak in 1 hour and maintain the same level for the 6 hours tested. We also performed an experiment to ensure that the sterility of the BCLs was maintained after injection of ketorolac. Swabs were taken from the alcohol-cleaned and uncleaned surfaces of the BCL blister packs. No growth was seen on the clean surfaces. We wondered next, what is it that drives this pain in some sets of patients? And does the use of cold temperature make any difference at the molecular level? We chose to explore the potential role of the TRPM8 and the TRPV1 channels in the perception of cold temperature. The CGRP, a neuropeptide implicated in several pain pathways. The interleukin-6, perpetuating dysregulated synthesis of pain mediators among several other functions. And the cyclooxygenase 2 enzyme, an important derivative of the arachidonic acid pathway. In order to understand if the cold temperature had any effect at the molecular level, the discarded BCLs were transported in phosphate-buffered saline to the laboratory and then subjected to a series of experiments. This included the thermomixer to separate the cells from the BCLs, followed by microcentrifugation at 4 degrees Celsius, and then addition of reagent for extraction of RNA. The converted cDNA was loaded into plates, and qPCR was performed for the analysis of gene expression. We then discovered Patients with high pain scores showed high levels of TRP expression, high levels of expression of calcitonin gene-related peptide, and also high expression of inflammation-related genes. What exactly did our study add? It gave us a novel, inexpensive technique to control post-PRK pain. It helps us understand the differences in expression of key receptors and enzymes in the pain pathway. And it further opens up a wide array of possibilities for treating pain through action at the level of receptors. Cold as a therapeutic agent has been a savior for centuries. But are we ready to be rescued again?